Hello everyone and welcome to Keys to Understanding NREMT Questions and Scenarios. This is a project that I have been working on recently to give students an easy, practical approach to all registry style questions. This walkthrough video will teach you how to analyze different types of information, which in turn will help lead you to the correct answer option. I hope that this video can benefit not only students preparing to take the National Registry computer-based test, but also for students that are actively enrolled in the EMT program currently. Thanks for watching and let's get started. We will start with the two types of questions that Registry will give you, either the definition knowledge questions or the scenario questions. The first type, which are the knowledge definition questions, require you to be familiar with intricate details from the text, lectures, and other resources. Simply put, these questions want to know how much time you have spent studying your textbook. These questions will include medical terminology, definitions, anatomy and physiology-based questions, and specific values such as what is the appropriate depth of compressions when performing CPR on an adult patient, or something like what is the flow rate through an oxygen regulator that is considered to be high flow oxygen. It's important to remember that in your class lectures, it is impossible for instructors to teach every single detail out of the text. However, every word in your textbook is fair game, so to speak, for Registry when it comes to examinations. Therefore, it is imperative as a student that you spend hours upon hours reading every chapter from your textbook, because a large portion of success in an EMT or paramedic program rests on the student's ability to study and memorize that key information. These questions are pretty straightforward and can be easily answered depending on how well you know that information. Later on, I will show you a couple of examples dealing with these types of knowledge questions so you can see really what it is that we're talking about. It's really important also for you to be aware of important descriptors in the questions, such as least, most, best, first, next, etc. This is Registry's way to truly convey to you what the question is trying to ask, such as what is the least important step or what's the most important step. And when they say stuff like that, they don't just put it in there for fluff, so to speak. They put it in there for a reason, and they want you to think about what is the least, what is the most, what's the best answer, meaning that there could be a couple of answer options that seem correct, but one of them is the best, depending on, again, how well you know the information out of the textbook. The second type of question that Registry will ask you are the scenario questions. These questions require reading comprehension and critical analysis, which means that you take a brief synopsis of any given patient and being able to utilize that information and come to, of course, the best conclusion or answer option. In essence, the scenario questions can really only ask you to answer in two different ways. Either, like you see number one, what is wrong with the patient? That is, what is the name of the medical emergency that they're experiencing? Or looking for some answer based on those same lines. Or they will ask you, number two, what are you going to do for this patient? As in, based on your analysis of this patient in the scenario question, what is the best course of action for this patient? How will you handle this patient? Or what interventions are you going to use for this patient? So scenario questions tend to be the most difficult because they have a lot of different variables that play into the patient's condition and can sometimes be pretty lengthy with information. That's why I created the 5 keys to understanding scenario questions that we're going to discuss here next. So the 5 keys to identify, for every scenario question we want to identify which information is invariably important and will help lead us to the right answer, and which information could lead us to overthink the question and potentially second guess ourselves. I believe that the easiest way to do this is to identify 5 different types of information, which are the 5 keys that you see here. These different types of information are numbered 1 through 5 in order of their importance. Number 1 is primary information. This is information that you should focus on the most because it's registry's way of conveying imperative information that will lead you to the right answer. This information is anything that explicitly relates to their immediate issue or emergency. The best example of primary information would be the patient's chief complaint or the presence of any life-threatening issues. Another example would be anything specific about the patient's medical history that would raise your index of suspicion of a serious underlying illness or injury, such as, say, a patient with a suspected hemorrhagic stroke who claims to have a history of hypertension. We know that uncontrolled hypertension can lead to the formation of aneurysms, which can rupture and cause intracranial bleeding, which of course can lead to a hemorrhagic stroke. Number two that you see here would be hallmark signs and symptoms. Hallmark signs and symptoms are signs and symptoms that are only found with one specific medical ailment or traumatic injury. Quite honestly, hallmark signs and symptoms are registry's way of giving you the correct answer without actually telling you the right answer. If you know these hallmark signs and symptoms well, you'll be able to equate them to a specific ailment, which will make your decision on an answer option that much easier. For example, we all know that both asthma and anaphylaxis present with difficulty breathing. We also know that both asthma and anaphylaxis present with wheezing lung sounds. Given just that information, we cannot decisively come to the conclusion about which one our patient is experiencing. However, given that anaphylaxis is an extreme life-threatening immune system response or allergic reaction, the presence of urticaria or hives on a patient is a hallmark sign and symptom for anaphylaxis, meaning again that it is specific to anaphylaxis only and not to any other respiratory related issue. Number three are keywords or phrases. Often associated with the primary information, keywords or phrases clue you into how bad, immediate, or progressed the patient's issue is. Examples include the use of keywords like severe and extreme. It is important to note the presence of these keywords or phrases because registry will put them in a question for a reason, and that is to convey the importance of specifics about your patient's condition. Number four are empirical findings. This information is evidence-based and factual, which means that this information is measurable and quantifiable. The most widely used example of empirical findings would be the patient's vital signs. This information isn't always bad, quote unquote, necessarily, in the sense that anytime you see vitals, they will indicate some sort of physiologic dysfunction. However, this information could help you denote the presence of serious issues like Cushing's triad, shock, or some other type of very immediate issue. And finally, number five is secondary information. Secondary information is best known as distracting information and could make you second guess yourself or lead you away from the correct answer. This information would include any information that has nothing to do explicitly with your understanding of the patient's emergency or chief complaint or your treatment of their condition. An example of this type of information would be something like you have a patient that you expect is experiencing a myocardial infarction, a heart attack. You do not have protocols to carry nitroglycerin on your ambulance, and your patient does not have her own prescribed nitroglycerin tablets, but her husband does. Now, the fact that the patient's husband has nitroglycerin should not mean anything to us. We know that we can only administer medications that are within our scope of practice, belong to either ourselves or the patient, and with approval from medical control or our protocols. And of course, you can bet that with this scenario, registry will provide an answer option in which you can give the patient her husband's nitroglycerin, which would of course be incorrect. So identifying the secondary information and not allowing it to influence your decision is paramount. Now, it is important for you to understand that not all of the 5 keys that we just discussed will be present in every registry scenario question. You may have a shorter question in which there are only one or two keys that you can identify, or you could have a longer, more detailed question that could have all 5 keys of information. We will see plenty of examples with the practice questions coming up here shortly. So here are some examples of definition or knowledge questions, the first type of questions that we talked about. As you can see, they are relatively very straightforward and don't require the same type of information analysis like the scenario questions do. These questions again want to gauge how well you remember details from reading the chapters in the textbook. Questions like the first bullet point, which is the leaf-shaped flap of tissue that prevents food and liquid from entering the trachea, is called the. This is an anatomy and physiology type question, and given the description, we should know that the correct answer is the epiglottis. The second bullet point, the proper technique for using the power grip is to. This question is asking whether or not you know what the power grip even is, how to explain it, and aspects of the proper lifting technique. The third bullet point, which of the following statements regarding breathing adequacy is correct, is asking if you understand what adequate breathing looks like or sounds like. You could see another question that asks the opposite and wants you to characterize signs of inadequate breathing. Again, all of this straightforward knowledge is explained in the textbook and should be easy to identify for any student that reads and studies the text consistently. Now we're getting into the meat of what we are talking about today, the scenario questions. As an EMS educator, here are some helpful hints that I have for you to remember when reading and analyzing these questions. So read each question very carefully, more than once if needed. Every word in a registry question is important and is there for a reason. Do not add your own information to the questions. That second bullet point underneath, read each question carefully, is something that I tell my students all the time. A lot of times students get mixed up or they start second guessing themselves, not really based on what the question tells them, but the supplementary information that they add to the question. Case in point, if something isn't stated explicitly in a scenario question, you shouldn't assume that it's there. You shouldn't read too much into the scenario questions. You should not add your own information. Second bullet point, read each answer option very carefully. So read the question very carefully, then read the answer options very carefully. It's very important for you to understand that for answers that have multiple steps, say they list it out like give the patient oxygen, load them into the back of the ambulance, and monitor them carefully en route. If they list out steps for you to take in the answer option, remember that every step in that answer option must be correct. No answer option will ever only be partially correct. Meaning that if they list out 4 things for you to do in the answer option, you can't agree with 3 of them and then say, well, that 4th thing is wrong. I don't really agree with that. I haven't seen it in the textbook. I haven't heard about that at all. I haven't studied that. That means most likely that that answer option is incorrect. So every part of that answer option must be correct for the entire answer option to be correct. And remember, of course, that there is only one right answer. You will run into scenario questions and even definition knowledge questions whose answer options, a couple of them, seem like they might be correct, and that's something we talked about, choosing the best answer option. There will be something between those 2 answer options that you think both could be correct that invariably makes one incorrect and only makes the other answer option the true correct answer. Identify the 5 keys, that information that we just talked about. This will help to ensure that you don't miss the essence of what the question is asking and ensures that you are focusing on the most important information. So Identifying all of these different 5 keys, or however many are present in a given scenario question, is going to be really, really important and beneficial to you for coming to the right answer option. If the scenario question ends with "you should," your answer will be the broad or overall treatment goal for that specific patient. The answer will not necessarily need to be the immediate next step. Whereas if the question ends with "after blank, you should," or something like "you should first," your answer will be the immediate next step. And the best way to come to the correct answer option for these types of questions is to strictly follow the NREMT medical and trauma patient assessment skill sheets. So the skill sheets that you must perform for the psychomotor examination, these are the skill sheets that are going to help you come to the right answer for these types of scenario questions. There's a reason that we stress so fervently in our program that you understand these, or you have these sheets memorized, especially medical and trauma, is because of these scenario questions. You need to look for a jumping off point, so to speak, so that you know what has already been accomplished in the scenario question. So, for an example, if they tell you, after you administer high flow oxygen to the patient, you should. So they give you that jumping off point. The last thing that's been completed for this patient's assessment and treatment is the administration of high flow oxygen. Now for the on the medical assessment sheet, you can see that after the administration of oxygen, the very next step would be to start assessing circulation. And if one of the answer options had to do with check a pulse or check skin signs or check for major bleeds, all 3 components that are listed in the circulation assessment for medical patients, that would be your answer, because it immediately follows what the question has already told you has been accomplished. So it's important to look for the ends of the scenario questions. If it just said "you should," again, that's going to be the broad overall treatment goal for the patient, not necessarily what is the immediate next step. If they give you that jumping off point, like after you do something, or you should first do something, or you should next do something, you need to identify that jumping off point, relate it to the medical or the trauma patient assessment skill sheet, and choose the immediate next answer that comes after that jumping off point. Okay, so here you see the 5 keys of information that we went over previously. As we go through the practice scenario questions coming up here in a second, I will highlight the 5 keys for you so that you can see and practice along with me in identifying these 5 keys. Primary information will be highlighted in blue, as you see. Hallmark signs and symptoms will be highlighted in red or orange. Keywords or phrases will be highlighted in that aqua teal color. Empirical findings will be highlighted in black, and secondary information will be highlighted in gray. As I read through the practice questions, I will give you a few seconds to pause the video so that you can practice highlighting the different information on your own. So, without further ado, let's get started with the practice questions. Number 1, you are assessing a 49-year-old man who, according to his wife, experienced a sudden, severe headache and then passed out. He is unresponsive and has slow, irregular breathing. His blood pressure is 190 over 94 millimeters of mercury, and his pulse rate is 150 beats per minute. His wife tells you that he has hypertension and diabetes. He has most likely experienced A, acute hypoglycemia, B, a ruptured cerebral artery, C, a complex partial seizure, or D, an occluded cerebral artery. So, like I said, I'll give you a couple seconds to pause the video so you can practice highlighting the different types of information before we move on. So now you see we can highlight some of those 5 keys. Here we see sudden severe headache highlighted in that orange color, and of course that would be hallmark signs and symptoms. You should know at this point that a sudden severe headache registry is always trying to convey to you that the patient has experienced a specific ailment. So, without revealing the answer option right now, if at this point you were reading through and you are experienced with registry type questions and you really know your hallmark signs and symptoms, you could actually only read this far, understand that that verbiage, sudden severe headache, is a explicit hallmark sign of what's going to be one of the answer options. You could technically stop reading here and pick the right answer option. But we're not going to do that. We're going to go through the entirety of the question here. We have he is unresponsive and has slow, irregular breathing, marked as primary information. That's explicitly important as to determining what the right answer is for this patient. It gives you some key descriptive factors about this patient that could play into either the treatment or the figuring out what is going on with this patient. So remember that the scenario questions are going to ask you either what is wrong with this patient and what are you going to do for this patient. So this question clearly is asking you, based on the information in this scenario question, what is the patient experiencing? His blood pressure is 190 over 94 millimeters of mercury. Of course, we can mark that as empirical findings. And his pulse rate is 50 beats per minute. Again, we mark that as empirical findings. His wife tells you that he has hypertension and diabetes. He has most likely experienced. You can see that we marked hypertension as primary information, and I'll explain why in a second. We marked diabetes as a secondary information. Again, this could be distracting information. If you see sudden severe headache, that elevated blood pressure, along with the other primary information that we've seen, the hypertension, diabetes really doesn't have anything to do with factoring in or out what this patient is actually experiencing or what the problem is. The fact that he has diabetes doesn't really play into our answer option because we don't see any other key signs or symptoms, primary information, or hallmark information that would let us know that this is a diabetic problem. So you should put all this information together and come to the conclusion that the correct answer option is B, a ruptured cerebral artery. We would call this a hemorrhagic stroke. It's the least common type of stroke, but easily the most deadly type of stroke. So hemorrhagic stroke, again, as a reminder, is a medical ailment in which a cerebral artery, a blood vessel in the brain, is ruptured. So now we have bleeding into or surrounding the brain itself. So with that knowledge of that this is a ruptured cerebral artery, we can mark sudden severe headache. Registry will always use that hallmark sign and symptom of specifically explaining it as a sudden severe headache. That should be a red flag to you always that registry is trying to get you to think about a hemorrhagic stroke. We can also identify that in blue, the primary information, he's unresponsive, which means that this progressed very rapidly, which again is conducive to the presence of a hemorrhagic stroke for this patient. The reason that I marked slow, irregular breathing as primary information is because if this question were to ask you how to deal with this patient or how to manage this patient, the presence of slow and irregular breathing would tell you that at a minimum this patient needs to be ventilated to correct that issue with tidal volume. So slow irregular breathing is important to us because that is a life threat, and we know of course that we need to treat life threats immediately with the correct intervention. Now this question again is asking you what's going on with the patient, But if it were to ask you, how would you initially manage this patient, the answer would be, I need to ventilate this patient with a BVM and high flow oxygen. So that's why I marked that as primary information. Again, it's important to understand that these empirical findings, we know that with the presence of a hemorrhagic stroke, the blood that's accumulating in or around the brain is going to cause an increase in cranial pressure. And the way that we recognize ICP, an increase in cranial pressure in the field, is the presence of what's called Cushing's triad. And Cushing's triad is 1, widening pulse pressures. That means the systolic and the diastolic blood pressure get farther and farther apart. As the systolic pressure, the top number, increases, the diastolic pressure, the bottom number, will decrease. Now, we don't necessarily see a range here because they only give us 1 blood pressure, but we can see with that 190/94 blood pressure reading, that is a marked difference between those two numbers. That's a huge spike in the systolic blood pressure and a diastolic blood pressure under 100. So that is significant to us because even though they don't explicitly give us Cushing's triad, it does play into it. So Cushing's triad, again, number 1 is widening pulse pressures like we just talked about. Number 2, bradycardia, and again, we can see that here with this 50 beats per minute that we marked as empirical findings. So we have 2 of the 3 criteria for Cushing's triad, and the last point of Cushing's triad is irregular respirations, and we can see that slow, irregular breathing that we marked as primary information. So with this patient, you actually do see all 3 indicators of Cushing's triad. So that is very pertinent information to us, that the presence of Cushing's triad indicates an increase in cranial pressure. The sudden severe headache and the history of hypertension, that tells us that the increase in cranial pressure is most likely due to a rupture in a cerebral artery, a hemorrhagic stroke. So again, why hypertension is so important. The number 1 cause of a hemorrhagic stroke is a ruptured cerebral artery or an aneurysm, which is a weakening of the vessel, and the vessel starts to balloon out, and eventually that vessel can't hold the pressure anymore and it ruptures. So the number 1 cause of a hemorrhagic stroke is a ruptured aneurysm in the brain, and the number 1 cause of an aneurysm is uncontrolled hypertension. So when we're looking at all of this information together, we can put it together like this. The patient has a history of hypertension, which we know can cause aneurysms, which we know can rupture and cause a hemorrhagic stroke. We know that a hallmark sign and symptom of a hemorrhagic stroke is a sudden severe headache. And we know that there is, in fact, what we would expect to see, an increase in cranial pressure, because we know Cushing's triad. And we know that this patient is presenting with Cushing's triad with the 1, widening pulse pressures of the blood pressure, 2, bradycardia, the 50 beats per minute, and 3, the slow, irregular breathing. So putting all that information together, you should come to the clear conclusion that it is not hypoglycemia, the patient is not having a seizure, and the patient is not having a occluded cerebral artery. That would be an ischemic stroke, in which case we would not see any of these major findings on the patient. So the only correct answer option is B, a ruptured cerebral artery. Question number 2, a 37-year-old male is having a severe allergic reaction to penicillin. He does not have an epinephrine auto-injector, and your protocols do not allow you to carry epinephrine on the ambulance. How should you proceed with the treatment of this patient? A, ask the patient if he has any diphenhydramine, which is Benadryl, tablets that you can administer. B, administer oxygen, transport at once, and consider requesting a paramedic intercept. C, remain at the scene with the patient and request for a paramedic ambulance. Or D, quickly determine if there are any bystanders who may carry epinephrine. So again, feel free to pause the video and identify any of those 5 keys that you see. So you can see here we've started to identify some of the 5 keys. And like I said, it's important to remember that not every question is going to present with all 5 of the key information to identify. Here we only have the keywords or phrases that we highlighted as severe, and then we have the primary information that is highlighted in blue. And remember, the primary information is the information you need to focus on the most. It's the information that's going to help you understand not only what the question is asking you to do or what they're trying to get out of you, but also it's going to play the biggest role in terms of finding the correct answer option. So it's key to understand that the keywords here, severe allergic reaction, it's interesting that they chose to describe this as not only an allergic reaction, but they chose to describe it as severe. And of course, most likely, our mindset is going to go to that the severe allergic reaction is most likely consistent with anaphylaxis, which is of course an immediate life threat, and we have to treat it appropriately. So of course, when you're reasoning, when you're thinking about this, okay, it sounds like the patient's having anaphylaxis. I need to treat this immediately. I understand how life-threatening anaphylaxis can be. It can develop into shock very quickly and lead to death of the patient very quickly. So as you're reading through this, the answer option you should be looking to incorporate, if it asked you what are you going to do for this patient, would of course be the administration of epinephrine. Now it's important as you keep reading through the question, this primary information, he does not have an epinephrine autoinjector. Uh-oh, that's bad, okay? But it's key information because it's telling you presently what you have to work with. Your mindset goes, anaphylaxis, I need to administer epinephrine. But registry tells you the patient does not have an epinephrine autoinjector. And reading further, your protocols do not allow you to carry epinephrine on the ambulance. So basically what registry is telling you based on this primary information is this patient is most likely experiencing anaphylaxis. You know you have to treat it with epinephrine, but there is no epinephrine available. So now we come at a crossroads, which is exactly what the question is saying. How are you going to proceed with treatment of this patient if you know the patient needs epinephrine, but there is none available presently at this time? Now again, don't start asking yourself, what if? Well, what if my partner's on his way with epinephrine? Or what if there's someone else that's there that has epinephrine? Don't start adding your own supplementary information. So carefully reading through the answer options again, we can come to the conclusion that the correct answer is B is the correct answer option here. One of the things that I like to do once I initially think that I have the correct answer option, I want to go back and convince myself of how the other 3 answer options are incorrect. It's basically a process of elimination that I like to apply. And if you can easily rule in or rule out answer options based on all or an aspect of the answer option being incorrect, then I want to do so as soon as possible. So before I move on to the next question, I always want to make sure that I can explain why the other 3 answer options are incorrect. So we're going to do that here. Answer option A asks the patient if he has any diphenhydramine or Benadryl tablets that you can administer. From a national perspective, remember that registry is testing you on a national curriculum, and per that national curriculum, they say that EMTs cannot give Benadryl. They do not have protocols for the administration of Benadryl, nor do we have any indications to give Benadryl to our patients. So it doesn't matter if anybody has Benadryl present, because it's not the first line treatment for an anaphylaxis patient. Of course, the first line treatment is epinephrine. So diphenhydramine is lower on our priority list, and very simply, it doesn't matter if anybody has Benadryl because we cannot give it per national registry standards. Answer option C, Remain at the scene with the patient and request a paramedic ambulance. Of course, you see the similarity between answer option B and C are both to request a paramedic intercept or a paramedic ambulance. So we actually like that. That part of answer option C is correct. And the reason being is paramedics carry epinephrine that's packaged not just in the epinephrine auto-injector. We carry it in vials and multi-dose containers. We don't necessarily need to be carrying an EpiPen. We can administer epinephrine to the patient in various other ways. So as an EMT, it's important to recognize that this patient is experiencing anaphylaxis most likely. We know that this is a life-threatening condition. It needs to be treated immediately, and that treatment should be epinephrine. So the goal is, as fast as you can, get somebody on scene or rendezvous with somebody or go on the way to the hospital as soon as possible so that this patient can receive that life-saving intervention. However, remember I told you that if they give you steps in the answer option, all of the steps must be correct. So we know that getting a paramedic or rendezvousing with a paramedic that can administer epinephrine is incredibly important, and that part is correct. But remaining at the scene with the patient is what makes C incorrect. We don't want to waste any more time on scene than we have to. The goal is rapid transport, rapid transport, rapid transport for this patient that's clearly experiencing a life-threatening condition. So a severe allergic reaction patient, he doesn't have epinephrine. We don't carry any epinephrine. This is a really dangerous situation. We don't want to waste any time on scene. We want to go to the hospital as soon as possible or try to get rendezvous with ALS as soon as we can. So that is what makes answer option C incorrect. And answer option D, quickly determine if there are any bystanders who may carry epinephrine. Again, per National Registry standards, we, in accordance with the 6 rights of every drug administration, we want to make sure that this is the right drug for the right patient. So either we are administering our medications that we carry on the ambulance as providers that we can administer universally to anybody that meets our protocol requirements, or we are helping to administer the patient's own prescribed epinephrine. Now, the question again in the primary information clearly states that the patient does not have an epinephrine auto-injector, nor do your protocols allow you as a provider to carry epinephrine. So there's no epinephrine on scene. We don't want to have some random bystander come forward, give us their prescribed medication, and administer that to our patient. Case in point, very simply, we're not going to use somebody else's drugs to treat our patient. It's either their drug or it's our drug that we carry. So of course that would make answer option D incorrect. And the correct answer option once again is B. We would want to administer high flow oxygen. We do want to transport it once. Again, that's what made C incorrect. We want to get this patient off scene as soon as possible. And consider requesting a paramedic intercept so that they can help us to administer that very important intervention of epinephrine. Question 3. Upon arriving at the scene of a patient with difficulty breathing, you determine that the scene is safe. You enter the residence and find the patient sitting in a chair and is in obvious distress. Your first action should be to A. Ask the patient what's wrong. B. Obtain a set of baseline vital signs. C. Assess the patient's airway status. Or D. Assess the level of consciousness. Feel free to pause the video to identify some of the key information. So now you can see we have some of the key information highlighted for you. We'll start with the primary information that we identified, which is the chief complaint. Chief complaints are always primary information. The chief complaint for this patient obviously is difficulty breathing. And that is going to be our nature of illness moving forward for this patient until we have anything to prove otherwise. So we're going to stick with difficulty breathing as the primary information. You determine that the scene is safe, The fact that the scene is safe is really secondary information for this question. If they gave you any reason to believe that the scene was not safe, the scene safety would be the most pertinent on your mind. Of course, in the textbook for the national curriculum, the most important consideration for any patient, any situation, any call is your safety first and your partner's second. But we haven't seen anything in this question so far to tell us that the scene is safe, so we're going to set that aside as secondary information and not let it intervene into our decision-making process when choosing an answer. You enter the residence to find the patient sitting in the chair in obvious distress. This is marked as teal, which is the keywords or phrases. And again, the keywords or phrases let us know how bad the primary information is. So this patient's having difficulty breathing, and it's so bad that we have determined or that we can see how hard the patient is working to breathe. Of course, breathing should be a very passive process. You shouldn't have to work at it. You shouldn't have to labor with it. So the fact that he is in obvious distress conveys to us how bad the difficulty breathing is. We know that this is a pretty serious issue. Your first action should be to, you see how I underlined first. I didn't in the previous slide, but I wanted to see if any of you were going to catch that descriptive factor first. And again, like I said, with these registry questions, you got to pay special attention to those. Now because, like I said, when registry gives you this kind of question, your first action, your next action, most immediate action, now it wants, per the National Registry skill sheets, it wants the absolute next intervention or step in the patient assessment process. So, like I said, when you find one of these questions that says your first action, your next action, your immediate action, in this case it's your first, you have to look for that jumping off point. Okay, where do I start? What's already been accomplished? So you read through the answer or through the question again. Upon arriving at the scene to find a patient with difficulty breathing, you determine that the scene is safe. You enter the residence and find the patient sitting in the chair and is in obvious distress. What they've given you in this question is the general impression. Remember that the general impression is your first nonverbal, non-physical contact with your patient. It has nothing to do with talking to them. It has nothing to do with touching them or assessing them in any other way than basically what you can just hear, see, smell when you get on scene. So that's where we're at. The scenario question gave us the general impression, and if you're following along on the National Registry skill sheet, you'll find the box that says general impression. Your first action after the general impression would be to assess the level of consciousness. Answer option D. So right at the beginning of the primary survey or the primary assessment on the medical assessment sheet, skill sheet, you can see that it says general impression, AVPU, which is assess the level of consciousness, and underneath that is going to be chief complaint and apparent life threats. So again, this question is asking you, this is a very simple question when you break it down, but it's asking you, do you know what a general impression is? Do you understand that in this question you haven't done anything than just observe the patient? And they're asking you for your first action. So you need to identify that jumping off point to know where you start at with the sheet, and your first action should be, or your answer option should be the first action after that jumping off point. So we determined the jumping off point was the general impression, and the immediate next step down is going to be level of consciousness, which of course is our answer option. Question 4. A 29-year-old male complains of a severe headache and nausea that has gradually worsened over the past 12 hours. He is conscious and alert and oriented and tells you that his physician diagnosed him with migraine headaches. He further tells you that he has taken numerous different medications, but none of them seem to help. His blood pressure is 132/74 millimeters of mercury. His pulse is at 110 beats per minute and strong, and his respirations are 20 breaths per minute and adequate. In addition to high flow oxygen, further treatment should include A, assisting him with his migraine medication and transporting without lights and sirens. B, placing him in a supine position and transporting with lights and sirens to a stroke center. C, applying a warm compress to the back of his neck and transporting with lights and sirens. D, dimming the lights in the back of the ambulance and transporting without lights and sirens. So I'll give you a second to see if you can identify any of the key information in this question. Here you can see now that we've highlighted some of the key information. So the fact that the patient has a headache and nausea, of course that is going to be the chief complaint, which is our primary information highlighted in blue. The teal information, severe headache, again describes how severe, or it describes how bad the issue is. So registry doesn't use words like severe and immediate and those kinds of descripting words like extreme. They don't use those words lightly. They don't put them in there just to put them in there. So the fact that he has a headache and nausea is what our focus is going to be on. That's his chief complaint. But the key word highlighted in blue, in teal, severe, relates to us how important this is, or how much of an issue this is. Other keywords or phrases: gradually worsened. So the headache and nausea have gotten worse and worse and worse over the past 12 hours. That's pretty significant. Primary information, the fact that he is conscious, alert, and oriented. So even in the presence of severe headache and nausea that has gradually worsened over the last 12 hours, at least he is conscious, alert, and oriented. We like that. That is a good sign of cerebral perfusion, that the brain is receiving what it needs, that he still retains enough cognitive function to be able to answer your questions appropriately, and just to be alert and oriented. To be conscious is beneficial, and it's an important thing to note. Also, the fact that the physician has diagnosed him with migraine headaches. Of course, when you read that information, you shouldn't automatically assume that this patient is having a migraine, but you have about a 99% certainty now that this is what the problem is. The fact that his physician has diagnosed him with migraine headaches in the past means that he has a history of this, and we know from lecture and from reading the textbook that this is exactly how migraines present. They can last a very long time: severe headache, severe nausea, photosensitivity, and as they go on, migraines get worse and worse and worse. So even just reading the first couple sentences of this question, we can pretty much already reserve ourselves to the point that this is probably a migraine, unless I have any other information that comes to light in the rest of the question. This is probably what it is. He's probably experiencing another migraine, but we'll keep reading and assessing the information just to make sure. The fact that he's taken numerous different medications and none of them seem to help, this is a really good distractor. This is a prime example of distracting information that registry likes to throw in. It doesn't really play anything to do with how we're going to treat this patient or our assessment of this patient. It just doesn't really make sense. It's pertinent information to gather, and it's good to put it in our report, but in the present situation, figuring out what's wrong with this person and treating this person immediately, this doesn't have anything really to do with us. So don't get caught up with information like this and saying, well, what medications did he take? Or how many medications did he take? What if he's having negative interactions? And what if he has associated signs? And don't get yourself, like I said, don't dig yourself into that hole. We can identify this as secondary information and set it off to the side and allow it not to influence our thought process. So we have some empirical evidence here. Blood pressure of 132/74, heart rate of 110 and strong. We like that. It's a little fast on the heart rate, but we like that it's strong in nature for the quality. And his respirations are 20 breaths per minute and adequate. Adequate's another word to look out for. That again tells you that it's a descriptive term that tells you, okay, his breathing is adequate. That means that we most likely won't have to administer the BVM if it comes to that point. So in addition to high flow oxygen, further treatment should include. Now, we saw an example of this in the last question. We saw an example of when they say you should first or you should next, which means you have to pick the immediately next answer option on the sheet, or the next step on the medical assessment sheet. Here it just says further treatment should include. It's not really giving you a starting point. It's saying in addition to high flow oxygen, not after the administration of high flow oxygen. So again, registry tries to get a little bit tricky, but hopefully walking through the questions like this is going to help you in the future. So in essence, this question that ends in you should is looking for the broad overall treatment goal. We want all of the answer option to be correct, and we want it to be overall the correct way we're going to handle, or we're going to treat, or we're going to transport this specific type of patient. So given the information, putting it all together, let's see if you guys can get the right answer option, which is answer option D, dimming the lights in the back of the ambulance and transporting without lights and sirens. So putting all the information together that we identified, especially the primary information, we can ascertain that the patient has a history of migraines, and that his presentation now with his present illness is extremely consistent with the presentation of a migraine headache. We looked at the empirical evidence, the blood pressure, the heart rate, and the respirations. We didn't really see anything significant that would let us know that maybe this is a headache that, like we talked about earlier, is something more than just a headache, like a hemorrhagic stroke. We're not really seeing signs of Cushing's triad or signs of increased cranial pressure, and that's why the vital signs were important in this scenario here. But we didn't really see anything stand out. We didn't really see anything significant. So going back to the book, going back to the national curriculum, registry makes very, very clear that when we're talking about headaches, a lot of people have migraine headaches. A lot of people have consistent or chronic migraine headaches. And these migraine headaches, because of their photosensitivity, because of their sensitivity to bright lights and bright sounds, it talks extensively about how to transport these patients. And when you look at answer option A, B, C, and D, they all have the same general idea in terms of it's asking you how are you going to transport this patient. It's not necessarily talking about treatment. It's talking about how are you going to transport them? How are you going to make them the most comfortable as to not aggravate their signs and symptoms of a migraine, or how are you going to transport them as to not aggravate their migraine? So again, reading through the other answer options to make sure that they are in fact incorrect. Answer option A, assisting him with his migraine medication and transporting without lights and sirens. The last part of answer option A, without lights and sirens, we do like that. We talked about their photosensitivity, their sensitivity to light, and their sensitivity to loud noises. Of course, lights and sirens, code 3, driving in the ambulance, is both of those, bright lights and loud noises. So driving without lights and sirens is exactly what we want, but again, like we talked about earlier, assisting him with his migraine medication, we do not have protocols or the knowledge basis to administer migraine medications to a patient. So we can rule out answer option A. Answer option B, placing him in a supine position and transporting with lights and sirens to a stroke center. So placing him in a supine position is neither right nor wrong. Ultimately, we would place the patient in their position of comfort, and of course the patient would be able to relay that to you, whatever their position of comfort is. So placing them supine isn't necessarily wrong. What makes B wrong is transporting with lights and sirens and to a stroke center specifically. There is no explicit reason to transport a migraine patient to a stroke center, especially if we can ascertain almost beyond the shadow of a doubt that they are not experiencing a stroke. If they're just experiencing a migraine, there's really no reason to take them to a stroke center. Answer option C, applying warm compresses to the back of his neck and transporting with lights and sirens. Again, the warm compresses for answer option C are neither right nor wrong. Usually in my experience, patients that are having migraines would rather have something that's cool, like an ice pack applied to the forehead or to the back of the neck. And again, you are more than welcome to offer that to the patient as part of their treatment. But the thing that makes answer option C wrong, again, is transporting with lights and sirens. So really the only feasible way, the only way that the book states to transport a migraine patient or to handle a migraine patient is to dim or turn off the lights in the back of the ambulance, as well as not driving with lights and sirens. Question number 5. You are transporting a 42-year-old male who experienced blunt abdominal trauma. He is receiving oxygen at 12 liters per minute via a non-rebreather mask, and full spinal precautions have already been applied. During your reassessment, you note his level of consciousness has decreased and his respirations have become shallow. You should A, perform a comprehensive secondary assessment to determine why his clinical status has changed. B, insert an airway adjunct if he will tolerate it and begin assisting his ventilations with a bag mask device. C, reassess his vital signs and then notify the receiving hospital of the change in his clinical status. Or D, suction his oropharynx to ensure it is clear of secretions and then increase the oxygen flow rate to 15 liters per minute. So I'll give you a second if you want to identify some of the primary or the key information before we move on. So now you can see that we've highlighted some of the 5 keys. We'll start with the blue highlight, which is primary information. Of course, the chief complaint is abdominal trauma. I know at this point you guys haven't reached the point where we started talking about trauma, but I thought this was a good scenario question to use, even if it is dealing with abdominal trauma. Later on, we're going to see how this is more of a medical type issue, or how the trauma has involved the respiratory system and why we need to act immediately. So he experienced abdominal trauma. Other primary information, he is already receiving high flow oxygen, 12 liters a minute, through a non-rebreather mask. So it is beneficial, it's good that the patient is receiving high flow oxygen. That's something that we would have wanted to do for every patient at some point. And for secondary information, we've identified full spinal precautions have been applied. Other than the abdominal trauma itself, we don't see any reason that the patient should be in full spinal precautions. The question didn't say anything about the abdominal trauma coming from some mechanism of injury that would involve the spine, but for whatever reason, the question tells us that he is in full spinal precautions. So we can identify that as secondary information and not let it distract us from what really needs to happen. What we want to focus on is that one of the last statements in the scenario question noted in that teal color for keywords or phrases, the respirations have become shallow. So we know that he experienced abdominal trauma. It was blunt abdominal trauma, so it wasn't penetrating. We can see that highlighted in teal. That tells us, again, what kind of trauma this patient sustained. We know that he's already receiving high flow oxygen, but now we see that his level of consciousness has decreased and his respirations have become shallow. So putting all that information together, we should come to the right conclusion that the answer option is in fact B. Insert an airway adjunct if he will tolerate it and begin assisting his ventilations with the BVM. So again, the star, so to speak, of this scenario question is that last phrase, that his respirations have become shallow. That's a key phrase because a decrease in tidal volume, remember tidal volume is the amount of air that you can bring into the lungs and move out of the lungs in just one breath. We can actually quantify that in a milliliter amount of air, but in the field we don't really have any type of device as to measure that milliliter amount. So the best way for us to determine whether or not our patient has appropriate tidal volume is adequate rise and fall of the chest. So this is important to know because every time that National Registry tells you that the patient's respirations have become shallow, or if they say anything about the respirations that denotes that the patient's breathing is inadequate, that their tidal volume is inadequate. They might use the patient is apneic, they're not breathing at all, that the patient is breathing rapid and deep, in which case air isn't reaching the alveoli the way that it should, or that their respirations have become shallow. Again, denoting that tidal volume is compromised, air is not reaching the alveoli, and therefore respiration, the exchange of gases, is not occurring. This is a life-threatening issue. The purpose of breathing, bringing air into the airway, is to get it all the way past the dead space, which is everything in the lungs that does not contribute to respiration, to that gas exchange, to get that air all the way down to the alveoli so that respiration can happen. If there is a compromise in tidal volume, if you're not bringing in enough air, that is a life-threatening issue. We need to correct that immediately. And the only way to correct it in this sense with compromised tidal volume is to actually use a device that will force air into and out of the lungs, which of course is the BVM. So that is why answer option B is correct. And you can take that to the bank. Anytime registry tells you that your patient is experiencing a compromise in tidal volume, the amount of air that they can bring into the lungs, the answer option will always be that you need to ventilate that patient. Now, it's significant that they tell you that the patient is already receiving high flow oxygen with a non-rebreather mask. You have to understand the fundamental difference between a non-rebreather mask and a BVM. The non-rebreather mask only increases the concentration of oxygenated air available for you to take in with every breath. The non-rebreather mask does not ventilate you. To ventilate means to bring air into and out of the lungs. The BVM is the only device that we have that actually ventilates a patient artificially. So the non-rebreather mask in this case is of no use to a patient with shallow tidal volume because the patient on their own volition is not breathing deep enough to get air all the way past the dead space and into the alveoli. That's why it's imperative to insert an airway adjunct to keep the airway open and to use the BVM again to push air all the way down through the dead space into the alveoli. So let's see why the other answer options are wrong. Answer option A, perform a comprehensive secondary assessment to determine why his clinical status has changed. This might be something that we want to do later on when we get to that point. However, you're presented with a imaginary fork in the road with this scenario question. You're presented with a life threat, the compromised tidal volume. If that's not corrected, the patient will eventually die or have extremely significant repercussions from not breathing appropriately. So answer option A is something we might do in the future, but it's not a definitive treatment for the immediate problem that's presented to us with the scenario question. Answer option C, reassess his vital signs and then notify the receiving hospital of the change in his clinical status. Again, this provides no information as to, or this doesn't provide a definitive treatment for the issue that we see in this scenario question, the compromised tidal volume. So B would come over C as well. D, suction his oropharynx to ensure it is clear of secretions, and then increase the oxygen flow rate to 15 liters per minute. D is incorrect because suctioning the oropharynx might be something that we need to do if the scenario question had made it explicitly clear that the airway was impeded by something like blood or by a foreign body or by vomitus. But like I said, do not add supplementary information into the scenario question. If the scenario question doesn't say it, then it's not necessarily something that we need to worry about. And because they don't give you any indication that the airway is full of something or impeded by a substance, we don't really know that we need to suction immediately. But that isn't explicitly what makes D wrong. What makes D wrong is only increasing the flow rate through the non-rebreather mask that the patient's already on to 15 liters per minute. And you have to remember that with the non-rebreather mask, all it does is increase the concentration of oxygenated air around the mouth and the nose. To have the non-rebreather work effectively, the patient still has to be able to bring in that oxygenated air under their own volition. And if the patient has compromised tidal volume, that means that it doesn't matter how many liters per minute through the non-rebreather or the nasal cannula we're giving them. If the patient can't, under their own effort, bring that air all the way down into the alveoli, we need a device to push that air down into the alveoli for them, which is again what makes B the correct answer. Question number 6. A 26-year-old female presents with heavy vaginal bleeding. She is conscious but restless. Her blood pressure is 84/54 millimeters of mercury. Her pulse is 120 beats per minute and weak, and her respirations are 22 breaths per minute with adequate depth. She tells you that she inserted a tampon about 2 hours ago. You should A. Administer high-flow oxygen, ask her to remove the tampon, and perform a detailed secondary assessment and transport promptly. B. Administer high-flow oxygen, perform a detailed assessment of her vaginal area for signs of trauma, place her on her side, and transport. C. Administer high-flow oxygen, place a sterile pad over the vagina, keep her warm, elevate her lower extremities, and transport without delay. And D. Assist her ventilations with a bag mask device, place one sterile dressing into her vagina, perform a rapid secondary assessment, and transport. So again, I'll give you a second if you want to pause the video and highlight the information on your own. So now you see we've highlighted the important information. The primary information in blue, of course, we know that the chief complaint is vaginal bleeding. We also know that she's conscious but restless. Again, that would be primary information because we know with when it comes to the female reproductive system, the vagina is incredibly vascular. There's a lot of blood vessels, the vaginal mucosa, the area of tissue surrounding the vagina is very vascular, which means it can bleed very heavily. And of course, with blood loss, we need to be cognizant about the amount of blood loss that any patient has lost. And we need to recognize any signs and symptoms that might suggest the presence of shock because of heavy bleeding. So she is in vaginal bleeding, but we know that she is conscious, but she's restless. This is significant because she is still conscious even in the presence of this bleeding. And this registry question even goes as far to describe the vaginal bleeding as heavy. So we know that there is a lot of blood loss, and you can see that highlighted in teal for keywords. Her blood pressure is 84/54 millimeters of mercury, and her pulse is 120 beats per minute and weak. This is empirical findings, or these are empirical findings, but they are very significant for just the same issue that we talked about a second ago, the presence of shock. Anytime you see hypotension, as you can clearly see here by the blood pressure, and tachycardia, a abnormally fast heart rate, you can see by the 120 beats per minute. Anytime that you see those two together in any patient, it always means that the patient is in shock. As far as registry scenario questions are concerned, when you see those two together, the patient is in shock. So we keep reading, and we know that her respirations are 22 breaths per minute with adequate depth. Adequate depth is a key word describing her respirations, and that's a good finding. We know this patient is in shock with heavy vaginal bleeding, which means we need to intervene immediately. But at least we know that she's conscious and that her breaths are 22 breaths per minute
with adequate depth. The fact that she tells you she inserted a tampon about 2 hours ago, that would be an example of secondary information. It doesn't play necessarily into us finding the right answer. Now, if they had made a mention of how many tampons she had gone through trying to control this bleeding, that might be significant in the sense of us trying to determine how much blood loss she's experienced. However, in this present scenario, all we know is that she has heavy vaginal bleeding. We note the presence of shock based on her vital signs, and we need to intervene immediately. And given the treatment for shock, which is number 1, high flow oxygen, either through a non-rebreather or a BVM, whatever you deem is appropriate. Number 2, thermoregulation, which is applying blankets or chemical heat packs to the patient to keep them warm. Number 3 is a position of comfort. If the patient is conscious, they will tell you their position of comfort, or if they are unconscious, their default position of comfort will be supine. And number 4 is transportation to the closest appropriate facility as soon as possible. So given that information and given the information in the scenario question and how we treat for shock, we can move forward and ascertain that the correct answer is in fact answer option C. Administer high flow oxygen, place a sterile pad over her vagina, keep her warm, elevate her lower extremities, and transport without delay. Again, like we just talked about, the treatment for shock is high flow oxygen through a non-rebreather or a BVM, whatever you deem is necessary. Thermoregulation to keep them warm, rapid transport, and position of comfort. So all of the aspects of C is correct. Remember, whenever registry gives you steps in the answer options, all of the steps have to be correct. The reason that we would elevate her lower extremities is we are creating our own systemic vascular resistance. And when the body goes into shock, you should know that one of the things that happens is immediately the release of epinephrine from the adrenal glands is going to circulate throughout the body, and epinephrine is going to cause a few things to happen. Primarily, what we're talking about here, epinephrine is going to stimulate the alpha-1 receptors to cause vasoconstriction. The blood vessels will constrict. And what's happening is the body is creating systemic vascular resistance. And what that means is the blood vessels in the upper and lower extremities are going to constrict, and they're going to start to force that extra blood out of the extremities and back towards the core to circulate through the vital organs that the brain needs to keep alive, or the brain needs to perfuse the most to survive. And this is part of the compensatory mechanisms that the brain enacts in the presence of shock. So the brain wants to keep oxygenated blood flow circulating to the organs that are most important, primarily the brain, the heart, lungs, and the kidneys. So if we elevate the lower extremities, we are assisting with that by using gravity to pull that blood from the lower extremities and move it towards the core, again, where the brain is going to circulate it to the organs that need it the most. So elevating her lower extremities, we would call that the shock position, and that is a correct treatment for somebody that is experiencing shock from bleeding of any mechanism. Now, answer option A, administer high flow oxygen, ask her to remove the tampon, perform a detailed secondary assessment, and transport promptly, is incorrect because we wouldn't necessarily ask her to remove the tampon. When we're talking about gynecologic emergencies, registry and the national curriculum is explicitly clear to neither remove or input any device or pad or sterile gauze into the vagina. So we never want to remove anything or place anything into the vagina during treatment of a gynecologic emergency. So that would make A incorrect. B, administer high flow oxygen, perform a detailed assessment of her vaginal area for signs of trauma, place her on her side and transport. This answer option doesn't look too bad, but the detailed assessment of the vaginal area for signs of trauma wouldn't necessarily be warranted with the information given in this patient scenario. We don't really have an MOI, and that answer option is very specific, doing the detailed assessment to look for signs of trauma specifically. If we had reason to suspect that this was vaginal bleeding from a traumatic incident, then we might do this later on, but it wouldn't be the immediate treatment, even in that case. Plus, this answer option has nothing to do with taking active steps to help control the bleeding by adding external pressure. Remember, you never remove or place anything into the vagina in cases of a gynecologic emergency. So that is why B is incorrect. D, assist her ventilations with a bag mask device. Place one sterile dressing into her vagina, perform a rapid secondary assessment, and transport. A couple parts of D are acceptable, but remember that every step in the answer option has to be correct for the entire answer to be correct. We have no indication to ventilate this patient with the BVM. Remember, we highlighted the information and talked about its significance. The fact that she has 22 breaths per minute with adequate depth. Remember, we only use the BVM if there is a noted decrease in tidal volume or compromise of tidal volume. Again, those patients would be excessively deep respirations, excessively shallow respirations, or that they are not breathing at all. Those are the patients that we always use the BVM, and we don't see that here. So we have no indication to use the BVM. And the part of answer option D that really makes it incorrect is the application of a sterile dressing into the vagina. And again, I can't stress that enough. Nothing should ever be inserted into the vagina for treatment of a gynecologic emergency. And that is, again, what makes D incorrect and ultimately C the only truly correct answer option for this question. Question number 7. A 50-year-old male presents with an altered mental status. His wife tells you that he had a quote-unquote mini stroke 3 years ago, but has otherwise been in good health. The patient is responsive, but unable to follow commands. After administering oxygen, you should repeat the primary assessment, inquire about his family history, prepare for immediate transport, or perform a head-to-toe assessment. If you want to take a couple seconds, you want to pause the video to highlight the information on your own, you're more than welcome to now. So we have highlighted the appropriate information. Of course, in blue for primary information, we have the chief complaint, which is altered mental status. We also have in blue the fact that the patient experienced a quote-unquote mini stroke 3 years ago. These mini strokes, as they are commonly nicknamed, are called TIAs, transient ischemic attacks. And what that is a blockage in a cerebral artery that took hold and caused the signs and symptoms of a stroke, but the body was able to break it up, the clot, under its own volition without any medical treatment within 24 hours, and thus blood flow was restored to that portion of the affected portion of the brain, and the signs and symptoms resolved themselves. Now, what's significant about that is, for National Registry, we need to understand what a TIA is, as well as understanding the very significant fact that patients that experience a TIA in the future have an extremely high chance of experiencing a real stroke, a real cerebral vascular accident. Patients that experience a mini stroke have upwards of a 70% chance of experiencing a true stroke in which the body cannot resolve on its own, that requires immediate treatment within the next couple of years. So the fact that he has altered mental status now and had a TIA 3 years ago suggests to us that there's a very good possibility that he is experiencing a true stroke now. The fact that he has otherwise been in good health is good for this theoretical patient. However, we don't want that to distract us in saying, oh, well, it's probably another mini stroke. If he's been in good health, then this probably isn't that significant either. Which is not the case, as you can see from the red highlighted information for hallmark signs and symptoms. The patient is unable to follow commands. Even though they're responsive, they cannot follow your commands. So this little bit of information that they've provided to us largely suggests that this patient truly is experiencing a stroke, which is an immediate issue. This patient needs definitive treatment at the hospital as soon as possible. So we know that we do need to act very quickly with this patient. Now, I underlined after in the phrase or in the statement, after administering oxygen, you should. Again, that gives us a jumping off point. We know that the last step that registry left off on was the administration of oxygen. And following looking at the answer options and following the National Registry medical assessment skill sheet, like I told you to do, we have our jumping off point, which is administration of oxygen. Looking at the answer options, you should know that after the administration of oxygen, the very next step that comes from an answer option listed would of course be answer option C, prepare for immediate transport. And this is a very simple scenario question. All of these answer options are things that we're going to do in our assessment, in the medical assessment. But again, if registry gives you a specific jumping off point, like they do here, they say, you've just administered oxygen, what should you do next? After you administer the oxygen, what's the next step? And very simply put, following the National Registry medical assessment skill sheet, from the answer options that are listed, the next one that comes in line after the administration of oxygen is immediate transport. Repeating the primary assessment is our reassessment much later in the sheet. Inquiring about family history is something we wouldn't necessarily do, but if you did, that would be in the sample history, which is after immediate transport. And performing a head-to-toe assessment is the secondary assessment, which again comes after immediate transport. So again, we know that C must be the correct answer. Question 8. You are treating a 45-year-old woman who was stung by a hornet and has a rash. She tells you that she is allergic to hornets and has her own epinephrine auto-injector. She also tells you that she takes medication for hypertension. Her breath sounds do not reveal any wheezing. Her breathing is unlabored, and her blood pressure is 154/94 millimeters of mercury. What should you do if you are not able to make contact with medical control? A. Administer her epinephrine, reassess her condition, and transport her promptly. B. Begin immediate transport and request an intercept with a paramedic ambulance. C. Give her oxygen, transport her to the hospital, and monitor her condition en route. Or D. Give her half the dose of her epinephrine in case her allergic reaction is delayed. Again, you can pause the video to highlight the information on your own if you so choose. So now we have all the information highlighted here. The primary information was that she was stung by a hornet. As far as we know, that is our chief complaint for this patient. We also want to highlight as primary information that she's allergic to hornets and has her own epinephrine auto-injector. At this point, without reading any further, we should know, okay, she is allergic to hornets, she was stung by a hornet, and her allergy is severe enough to warrant her having her own prescribed epinephrine auto-injector, her own EpiPen. So at this point, we know that she has a history of severe allergic reactions to hornets, and that she is prescribed an epinephrine auto-injector that we can use if it gets to the point that we determine that she is in fact in anaphylaxis. Remember, the only indication for the use of epinephrine via the auto-injector as an EMT is the presence of anaphylaxis. So we can mark as secondary information that she takes medications for hypertension. That's part of our history taking. It's good to note that she does also have a history of hypertension. Hypertension is a relative contraindication for the use of epinephrine. Like we talked about a couple slides ago, epinephrine makes your vessels constrict, which of course raises your blood pressure. So having a pre-existing issue with hypertension can cause some issues with the administration of epinephrine, but it is a relative contraindication, which means even in the presence of hypertension, if the patient is truly experiencing anaphylaxis, a life-threatening emergency, we are not going to withhold the life-saving intervention of epinephrine just because she has hypertension. So in this case, we can rule that as secondary information because we don't want it to distract us. If this patient truly needs epinephrine, we're going to give it to her regardless. But we're going to find out here in the next sentence that we marked red with the hallmark signs and symptoms. Listening to her lung sounds, we don't hear any wheezing, and her breathing is unlabored. This is incredibly significant because it does not matter how severe an allergic reaction is. It is not considered anaphylaxis until the airway is involved, which means if the bronchioles start to constrict and cause difficulty breathing or wheezing, that would be grounds to call this patient or determine that this patient is experiencing an anaphylactic reaction. And the fact that her breathing is unlabored also tells us that the airway has not been affected up until this point. So given those 2 points, the absence of wheezing and the absence of labored breathing would let us know that we cannot classify this patient as being anaphylactic at this point, and we can also corroborate that with the empirical findings of her blood pressure being hypertensive. So remember that what makes anaphylaxis a type of shock is it falls under the umbrella of distributive shock. And the key issue with any type of distributive shock is the widespread vasodilation across the entire body. And when the blood vessels over the entire body start to dilate to that magnitude, we can expect the blood pressure to drop significantly. So given that she is still hypertensive, that there's no wheezing and her breathing is unlabored, would all corroborate to us as providers that she is not currently in a state of anaphylaxis. So we are not going to administer epinephrine, which is key to finding the correct answer option for this question. The essence of the question, however, is what should you do if you are not able to make contact with medical control? If you are not able to make contact with medical control, then you have to fall back on your standing orders. And given our knowledge of standing orders, given our knowledge of how to care for patients, and the knowledge that we've ascertained that she is not currently experiencing an anaphylactic reaction, would lead us to believe that the correct answer is in fact C. Give her oxygen, transport her to the hospital, and monitor her condition en route. This is a tricky scenario question just because in EMT school and in paramedic school, you're hammered so much with anaphylaxis gets epinephrine all day long. So it's incredibly important for you to be able to evaluate the information like we're doing here with the 5 keys to help you understand that, yes, we want to give epinephrine for somebody that's in anaphylaxis, but based on her signs and symptoms, her presentation, this patient is not currently in anaphylaxis. So C is the perfect answer option. We want to give her oxygen, transport her as quickly as possible to the hospital, and closely monitor her en route. We're not saying that this patient's condition isn't going to change. She could very well start to slip into anaphylaxis while we're transporting, so we want to keep a close eye on her. But we are not going to administer epinephrine in this case because her condition does not warrant it. So A is incorrect because of the administration of epinephrine. B is incorrect because uh, it has the intercept with a paramedic ambulance. Now, really, the only thing that I can think of as to why you would request the intercept with a paramedic ambulance is so that they could administer epinephrine. And that's not warranted for two reasons. One, she has her own EpiPen. And two, again, this patient is not currently in anaphylaxis, and so the administration of epinephrine is not warranted. D is incorrect because with the EpiPen, the auto-injector, we cannot control how much of the medication actually is given to the patient. We either administer the EpiPen and all of the medication is given. For adult dose, it's 0.3 milligrams of epinephrine, but we cannot half the dose or quarter the dose or anything like that. So D is incorrect based on the standpoint that if you give the epinephrine autoinjector, it's either the full dose or it's none of the dose. So again, that's what would make C the correct answer. Question number 9. A man was found unresponsive in his bed at home. There is no evidence of injury and the patient's medical history is not known. The patient's face is cyanotic, yet the pulse oximeter reads 98%. Which of the following would most likely explain this? A. Severe pulmonary edema. B. Carbon monoxide poisoning. C. His extremities are cold. Or D. An increased body temperature. Again, I'll give you a couple seconds to pause the video if you want to highlight the information on your own. So now we have the important information highlighted. The primary information in blue is that he's unresponsive. That is very significant, and as far as we know, is his chief complaint. There is no evidence of injury is also primary information. That's a good thing to know moving forward. The fact that his medical history is not known isn't explicitly important to us, and we don't want to let that distract us. We know that he's unresponsive, and we're going to find out in the next sentence what the key issue we identified is. So the fact we don't know his medical history is not going to factor into our primary assessment for this patient and immediate treatment for this patient. What we do know is that the patient's face is cyanotic. What that means is the patient's face is blue. There's bluish hue now to the skin. And of course we know that cyanosis found on the body means that the patient is experiencing hypoxia, which is low oxygen levels. When a majority of the blood that's carried through the vessels has become oxygen poor, it reflects the light off of the surface of the skin in that bluish color, and that's where we see the cyanosis. So cyanosis always means that the patient is hypoxic, and their oxygen levels are too low. However, we also see that the pulse oximeter, which tells us an estimation of how much of their blood is saturated with oxygen, tells us 98%. So we're seeing this is incredibly significant when you put these together, because we're seeing that the pulse ox is telling us that the patient's bloodstream is 98% saturated with oxygen, but we clearly see the presence of cyanosis, which tells us the exact opposite. And this is hallmark for, if you remember, the teaching on one of these issues that are listed in the answer options. Only one of these answer options explains how the patient can be cyanotic, but still have a pulse oximetry reading of 98%. And so putting all this information together, we should easily come to the conclusion that the answer is in fact B, carbon monoxide poisoning. Remember that carbon monoxide has a 270 times greater affinity to bind to hemoglobin than oxygen does. And what that means is hemoglobin is the protein component in red blood cells that actually attaches to and carries oxygen through the bloodstream. Carbon monoxide binds to hemoglobin 270 times more than an oxygen molecule does, which means if there's carbon monoxide present in the bloodstream, it's going to take up all those valuable spots on hemoglobin, and oxygen is not going to be able to effectively be transported through the bloodstream. So we also know, very significant, as it states in the book, that because of this, when carbon monoxide is attached to the hemoglobin, it will serve the same function in the sense that the pulse oximeter is still going to pick up on the presence of carbon monoxide as if it were oxygen that was attached to the hemoglobin. So we see in the patient's presentation that clearly something is wrong, and the cyanosis alerts us to it's most likely a respiratory issue, but we know that carbon monoxide does in fact affect the pulse oximetry reading, and it will give you a false high. If you were to take the carbon monoxide out of the bloodstream and truly be able to assess this patient's pulse oximetry reading, it would most likely be in the high 70s or low 80%, which is incredibly dangerous. So your understanding of the fact of what carbon monoxide is, the fact that the only answer option out of the ones given to you that can cause the cyanosis and still show a false high reading on the pulse oximeter should alert you to the fact that, of course, B is the correct answer. Question 10. You are transporting a 40-year-old male with a documented blood sugar reading of 480 milligrams per deciliter. The patient is semi-conscious and breathing shallowly and is receiving assisted ventilation from your partner. You should recognize that definitive treatment for this patient includes A, oxygen, B, glucagon, C, insulin, or D, dextrose. I'll give you a second to pause the video so you can highlight the information if you want to. So now we have the pertinent information highlighted. In blue for primary information, we see that the blood sugar reading is 480 milligrams per deciliter. This is a blood glucose value that we get, but it's significant in terms of primary information based on the fact that this is incredibly high. This would be documented hyperglycemia. Remember that per the national curriculum, the normal blood glucose range for an adult is between 80 and 120 milligrams per deciliter. So a reading of 480 tells us that this patient is incredibly hyperglycemic. So given that, we can see that starting to affect the patient physically because we see that he is semi-conscious, and we also see that he is breathing shallowly. Now, remember that registry can ask you, in essence, two types of questions from their scenarios, which is what are you going to do for this patient, or what is wrong with this patient. So this is an example of a quote-unquote, what are you going to do for this patient? But you should remember that putting all the information together might not necessarily be the answer that we think it's going to warrant from us. And what I'm trying to say by that is I just discussed with you a couple slides ago that if a patient is breathing shallowly, a compromise in tidal volume, that the first thing we need to do is assist their ventilations with a BVM. But of course, we can see that our partner is already doing that, which means that that is satisfied. So that is not going to be what the question is asking us about, and we can kind of put that to the wayside because that's already being handled for us. Now, it's important for you to realize the core of this question is this last statement. You should recognize that definitive treatment. Now, I highlighted that in blue as primary information because definitive means long-term care, ALS provider care, higher level of care for this patient. To you, as an EMT student, definitive should mean in the hospital with doctors and nurses and higher level providers and advanced diagnostic equipment. They're asking you, given these signs and symptoms, given what you know about hyperglycemia, given what you know about the relationship between glucose and insulin. A patient that is extremely hyperglycemic, definitively, from a higher level of care standpoint, is going to need what intervention? And based on all that information, we should easily come to the conclusion that the answer option is C, insulin. And this is the correct answer, of course. Remember that insulin is the cellular mediator hormone that stimulates the cells to take in glucose from the bloodstream. If insulin is not present in adequate amounts, then glucose is not able to enter into the cell to become metabolized into cellular energy, which is ATP. And if that glucose has nowhere to go, or it's not able to go into the cell, it's going to start building up in the bloodstream. So when we do a poke, so to speak, of the patient's finger to get that drop of blood to take a blood glucose test, and we see that it is that high, outside of the normal range of 80 to 120 milligrams per deciliter, we can assume that this patient that has a documented hyperglycemic issue is low on insulin, the hormone that allows the cells to use glucose. So we also understand that EMTs and paramedics in the field cannot administer insulin. We don't have the protocols or the training for it. So this is the perfect answer, answer option C. We know that the patient needs insulin so that the cells can metabolize that excess glucose, and we know that insulin is only given by doctors and nurses in the definitive setting, and that's why C is correct. Oxygen isn't the immediate answer, just because oxygen is not going to resolve this issue. B, glucagon. Glucagon is a hormone that's also produced by the pancreas, but glucagon stimulates the liver to release a compound called glycogen. And glycogen is extremely long chains of glucose that the body can use for long-term storage of energy or long-term usage of energy if we go without eating for a long time. So glucagon's ability to tell the liver to release essentially more glucose is only going to make this problem worse. And D, dextrose, is in essence pure sugar water. And of course, for this patient that's hyperglycemic, if the issue is too much glucose in the bloodstream, we don't want to add more glucose into the bloodstream. That's going to make the issue even worse. So the only true definitive treatment for this hyperglycemic patient, again, is C, insulin. So as a review, now that we've gone through those scenario questions, practicing with highlighting the 5 keys, I want to reiterate to you that you need to read all the questions and answers carefully. You don't want to miss out on that key information, and you don't want to read too quickly and pick what you think is going to be the correct answer option without truly evaluating all of the information in both the question and the answer options. You want to remember to identify the 5 keys in each scenario. Remember that not all 5 of the keys are going to be present, but some of the ones that we're most concerned about, again, would be the primary information, what is explicitly related to you coming to the right conclusion, the hallmark signs and symptoms, which are signs and symptoms, again, that are specific to only one issue, and that's going to lead you to understand that the patient is experiencing a specific ailment, or realizing that they are experiencing that ailment and then choosing the correct treatment for that ailment, and the key words or phrases which describe just how bad one of the patient's signs and symptoms are. You need to remember to immediately eliminate any distracting answer options or information in the questions. You don't want those to get in the way, and you don't want them to take you away from what is eventually going to be the correct answer option. That distracting information in the question could lead you to focus too much on that distracting information and skew your thought process while you're trying to pick an answer option, or the distracting answer option itself which seems good, but it's not completely correct, and it makes you second guess yourself, which is the next point down. Do not second guess yourself. Most of the time, you recalling information, reading through the first time, and making a decision on an answer option, most of the time you would be correct with your first guess. So the more you second guess yourself, the more you run into overthinking a question and an answer and end up changing your correct answer to a wrong answer. So go with your gut, so to speak. If your gut is telling you that the answer option is right, don't second guess yourself and go with what you first picked. And of course, keep studying and good luck. I hope that this has helped you in your future endeavors of studying. And I want you to apply what we talked about here to even your homework questions and your quiz questions and see if this system starts to work for you. And of course, take this and apply it to your midterm exam, your final exam, and of course, the National Registry exam.